Hi everyone, welcome to another Monty Hart lecture. Today we have Dr. Thomas Lüscher, who will be speaking about AI and machine learning in cardiovascular medicine. It's a real honor to have Dr. Lüscher today with us. He studied medicine at the University of Zurich and obtained board certification in internal medicine and cardiology in Switzerland and is GMC certified in the UK. He later trained in the Mayo Clinic in Rochester in cardiovascular physiology and cardiology and was professor of pharmacology and director of clinical pharmacology at the University Hospitals Basel. Then he became professor and vice chairman of cardiology at the University Hospital Bern and later professor and chairman of cardiology and director of the University Heart Center at the University Hospital in Zurich. Since 2017, he has been the Director of Research, Education and Development and Consultant Cardiologist at the Royal Brompton and Hartfield Hospitals and Professor of Cardiology at King's College in London, UK, but he still works as well in Zurich. Dr. Lüscher has mentored numerous physicians and scientists from around the world, with many holding chairs and directorships at universities and major hospitals in Switzerland, Europe, Asia, and North America. His research is translational and focuses at the basic level on endothelium-derived mediators and their alteration with aging, atherosclerosis, lipids, and inflammation, as well as at the clinical level on coronary artery disease, acute coronary syndromes, and heart failure. He is among the 0.1% most cited scientists with an H index of 151. He's an editor of the ESC textbook of cardiovascular medicine and the Manual of Cardiovascular Medicine. He lectures worldwide and is very active on social media. He has his own YouTube channel that you can check out if you want, Inside Cardiology. He was also the editor-in-chief of the European Heart Journal from 2009 to 2020, now the top journal by impact factor in cardiology, and continues also as a senior editor. He is currently the president of the European Society of Cardiology until 2026. Thank you so much for taking the time to spend an hour with us. We're very appreciative of your time. Thank you.
Well, thank you very much for this introduction. I'm delighted to be with you. Unfortunately, not in person, but I think I can still talk reasonably well about artificial intelligence in cardiovascular disease. Now, the human brain is the crown of the evolution. We are a neuronal network, really, with 8 billion neurons, as it has been estimated, and 100 trillion synaptic connections, a real crown of the evolution. Now, the question is, if it's a neuronal network, can a computer match that? And of course, the next question is, can the computer surpass that? Because there's no limit in how many neurons and connections you will develop. And there was really a historical moment in time in Philadelphia in 1996 and later in New York a year later, where Garry Kasparov, the then incumbent chess champion, from Moscow, but then living in the US, if I remember well, who fought against Deep Blue, the IBM computer that learned how to play chess. And this program was so strategic in nature that Kasparov lost twice. So this is really a historical turnaround. So how can we apply this technology to medicine that has been developed initially in chess, that is also a very strategic and forward-thinking game like medicine is, so in particular in cardiology. And if we look at this, we can say today we have genetics often, and even more so in the future. We have clinical data and demographics, patient history, and the like. And we have biomarkers, we have lipids, all the risk factors, cardiovascular risk factors. We have an ECG, as cardiologists in particular. And we have also imaging, because the heart is the hidden organ, and we need all these to get a big picture of the patient. And then we put everything in a basket called computer, maybe a big computer where we can enter all the data, hundreds of parameters, training and derivation cohort. And for that, we need a black box, which is only for the physician a black box, not for mathematicians, because they are actually mathematical tools such as logistic regression, subvert vector machine, random forest, XGBoost, and others. And you end up eventually with a first algorithm. Now, this is not good enough, because as a drug or a device, an algorithm can also be good or bad for a patient. And we have to prove this. So it has to travel well from, let's say, from New York to San Francisco, or from London to the continent, where we usually use another verification cohort. Where I work now in London, we take the national cohort in the UK, and then we go to Sweden, to Sweetheart or other Swedish registries, or to Switzerland, particularly for the infarct registry. And then we test it again, and eventually we come up with a confirmed algorithm. Okay, so once we have that, the question is, what can we do with it? Of course, we can analyze genetics and their outcome. We can use the face of a patient, the retina, the voice, the ECG, imaging, diagnostics, and prediction. So let's look at face recognition. This is what you see first when the patient enters your surgery. And then, of course, as a good physician, you immediately judges his age, his biological age, and you look at his chronological age, you look at his wrinkles, his face expression, his body habit, and so on. And this can be used. And the first paper came when I was an editor to the European Heart Journal out of China, not accidentally so, because they're masters in deep learning to detect coronary artery disease on a facial photo. And what they did is what you see when you shave in the morning or you put your makeup on. It looks at your hair, your wrinkles, the boldness, then of course the eyes, the wrinkles on your face, on your front, and in the changes in your earlobe. And it comes up with a decent prediction of three-vessel coronary artery disease. When you look at the area under the curve, the algorithm was 0.757, is not bad, is of course much better than flipping a coin, is not perfect yet, but it was better than Diamond Forrester. Logistic regression was about the same. So there's room for improvement, but it shows the potential of this new technology. And then the next is speech. When your mother called you and said, "Oh, you don't sound very healthy," she was right. And the algorithm can learn this as well. So this is a study from my friend for Amir and Eliezer Edelman from the MIT in Boston, and some other colleagues from Israel. And they took patients that presented with acute decompensated heart failure into their hospital in a congested state. Then these subjects or patients had to record 5 sentences in their native language, because in Israel there are different languages because of immigration. And then they treated them with diuretics and all the goodies we have at hand to treat heart failure. And once they were dry clinically, then they had to come up with the 5 same sentences. And then the algorithm learned, this is a patient in congested, this is in dry state, and so on, until he was able to pick up that this patient, based on his voice, is congested. Because congestion, we learned, is not just in the lungs, it's on the vocal cords as well. But there's more to that. They developed out of this a vocal biomarker and showed a prediction. And they confirmed that the biomarker, this vocal biomarker, is associated with hospitalizations on the right panel. When you look at quartiles 1 to 4, they could separate patients very nicely in their probability based on a vocal biomarker to be hospitalized in the future. And of course, overall, also cumulative survival probability was separated very nicely on the left-hand side. Then we have an ECG, and we thought we are the masters of the ECG, but we're not, as I can tell you here. This is from my friend Paul Friedman from the Mayo Clinic, where I had the privilege to train. And this is an AI-enabled ECG algorithm for the identification of patients with AFib during sinus rhythm. It is retrospective in nature, but it's still impressive. So they took patients that had an echo and more or less at the same time an ECG, and they looked backwards in history whether they had atrial fibrillation, and then saw whether the algorithm can detect on the sinus rhythm ECG that the patient had a history of AFib. And indeed it could, and you can see this is quite a remarkable C index between 1.8, 0.9, both in the initial, but also in the secondary analysis. But there's more to the ECG. This is screening for contractile dysfunction of the left ventricle using an AI-enabled ECG. Here, indeed, they took patients with an echo and more or less at the same time an ECG and told the algorithm, this is a patient with left ventricular dysfunction, this is his ECG, this is one with normal ejection fraction, this is his ECG. And what they could do, I mean, they started with a huge number, as you can see on the top, with 625,000 patients with an ECG and a TTE. And then, of course, they started with 35,000 to train the algorithm, then with about 10,000, roughly 9,000 to validate it for internal validation. And then for final validation, they took another 50,000 patients with this documentation. And what they found was then, of course, that this algorithm was able to predict left ventricular dysfunction with a C index of 0.9. So it's really quite impressive, almost perfect. And it was quite, quite effective in most subgroups, maybe in elderly females, where, of course, they had also less patients that didn't really seem to be that optimal. But other than that, the odds ratio was quite good. And what they further showed is that over time, in the red line, those who had indication of left ventricular dysfunction based on 10 beats of an ECG, they actually developed heart failure over time. In the blue line, you see those initially classified with low ejection fraction, with a normal ejection fraction. Some of them also developed heart failure, probably HFpEF. But this is an amazing progress because it may allow a GP that has an ECG but not an echo to actually determine which patient would deserve an echo to finally confirm the diagnosis of left ventricular dysfunction and potentially heart failure. But of course, we have to evaluate these things. And so we need randomized trials to show that algorithms are more precise, faster, and ideally also better than average clinical practice. And this is a study from Taiwan with 12,000 patients presenting in the emergency room with acute cardiac conditions. And one group of patients received an AI-enhanced ECG analysis. The other ones, just usual care. It's a pragmatic randomized clinical trial. And what they found is that in all patients on the left, there was not much difference. But when they looked at the subgroup that was considered high risk by the AI ECG, there the patients that had a doctor that used an AI-enhanced ECG had a 30% lower mortality than those that were going through the usual care track. Now, the low-risk population, there wasn't any difference. So this is a fantastic trial, and this is what we will need in the future. In fact, when you look at this paper published in Lancet Digital Health last year, you can see that there are randomized controlled trials of AI in clinical practice across countries and specialties around the world. And so AI algorithms must be evaluated like drugs or devices to assess whether they are faster and equally good, more precise ideally, or even superior in insight into the characteristics and the outcome of a patient. And then, of course, we have imaging. And imaging, of course, is a very, very important tool because the heart is the hidden organ, and the features of pictures are particularly suitable for AI algorithms, not just in cardiology, but also in pathology, in dermatology, and in many other visual disciplines of medicine. And in imaging and in cardiology, as you know well, we use echo, we use computer tomography, and we use cardiac MRI. And I would like to start with echo. And here there is an initial study published some years ago in 2019 on automated echocardiographic quantification of left ventricular ejection fraction without volume measurements using a machine learning algorithm mimicking a human expert. And on the left, you see machine learning, and on the right, clinical readers. And you see the correlation, which shows the precision of the measurements. And on the down below, you see in a Bland-Altman plots the variation, the variability of the measurement. And you can see what we all know, echo has quite some variability. And this is true for machine learning and clinical readers alike. If anything, the machine learning was a bit more dense in the points, as you can see well on this picture. Then, of course, there is also left ventricular assessment with artificial intelligence to improve the diagnostic accuracy of stress echocardiography. And they looked at the wall motion scoring, the automated AI analysis of the echocardiogram itself, that you can see here, and then wall motion scores and AI analysis. And of course, they did this in a significant number of patients. And you can see here on the left, wall motion score index, left ventricular ejection fraction estimates, and global longitudinal strain. And you can see in red the peak LV ejection fraction, the change in ejection fraction, and the rest left ventricular ejection fraction. And particularly at peak, the performance is quite substantial, as it is for the wall motion index and longitudinal strain. There's still improvement needed here. As you can see, it's far from perfect, but it's certainly an impressive first step in this area. You can also look at mitral flow Doppler analysis using deep learning from this study out of Rochester, Minnesota. And you can see the flow chart of fully automated mitral inflow Doppler analysis. On the left, where you have this typical AE waves for the early filling of the ventricle and the atrial kick. And on the right, you see the automated mitral inflow analysis compared to an operator. And you can see the automated AI-based one on here on this side, and here the operator. And you see the precision is quite remarkable for these different analyses. The Bland-Altman plot was not as convincing, really, but with deep learning, there was some more precision eventually. And then there is also computer tomography. And here is a schematic of a coronary artery. And you can see here, this would be a vulnerable plaque with lots of macrophages, neutrophils in it that produce lots of cytokines that you can measure here in the blood, as we do it in clinical practice when we measure interleukin-6, for instance. But these cytokines are not just released into the bloodstream, but they're also released towards the perivascular fat. And there it will reduce the adipose differentiation, it will increase edema, water content, and lipid accumulation will go down. So this changes the feature of this tissue in the radiogram, the radiomics analysis. And the question is, can we use this to predict who will have an event and who will not? And for that, Charalambos Antoniadis and his team developed the fat attenuation index and evaluated in large cohorts. And you can see here first one on the top, the derivation cohort, and down below, the validation cohort for all-cause deaths or for cardiac deaths. And you can see for cardiac deaths, it separates really nicely for above the median fat attenuation index and the fat attenuation index below the median. So it shows that really inflammation, as proposed by Peter Libby, many others in our group as well, is crucial for vascular dysfunction, plaque vulnerability, and eventually erosion or rupture in the coronary circulation, and is in fact predictive of what happens. Now the question is, and this is something that, of course, as an interventionalist, I always was focused for many years on stenosis. But the question is it stenosis only, or is it just a plaque? And here is another paper in the Lancet last year from the orphan study. And what you see here are all patients. These are large numbers. And this is quartiles of the fat attenuation index in the LAD. And you see that it is dose dependent. The more inflammation you have, the higher the fat attenuation index is, the more you have the higher is cardiac mortality over a 10-year period. These are patients without obstructive coronary disease. Still very important. In fact, those with obstructive coronary lesions were, if anything, at a similar risk. I mean, the scale is different, as you can see here, but still it's amazing that also those without obstructive coronary disease were at the increasing risk with increasing inflammation. It was not just mortality. The same was true for MACE. Again, make sure that you notice that the scale is different for those two groups, but still, even if you have no obstruction but inflammation, you are at quite a risk. Now, what about diagnosis?
Dyspnea and was found to have third-degree.
That is my friend Emily.
Coronary angiography revealed no abnormalities in the coronary arteries, and pulmonary artery CT was negative. Echocardiography and MRI preserved self-function in both ventricles. Following the clinical findings, a cardiac resynchronization therapy defibrillator (CRTD) was implanted. Subsequent FDG PET-CT imaging revealed focal tracer uptake in the cardiac septum, indicative of a potential non-ischemic or inflammatory cardiomyopathy. Based on the presented case details, the most probable diagnosis for this patient could be cardiac sarcoidosis. This is suggested by the combination of third-degree atrioventricular block AV block 3, preserved left and right ventricular systolic function, normal coronary arteries, and especially the focal accumulation of the tracer in the septum of the heart on FDG PET-CT, which is
so basically
of inflammatory activity. Cardiac sarcoidosis is a multi-system granulomatous disorder that can affect the heart, leading to various cardiac manifestations, including conduction abnormalities like AV block, arrhythmias, and potentially heart failure if left untreated.
So that's not bad, I would argue. And this is a complex case that not every physician would be as proficient as she was. And this was further tested with, in this very paper in the New England AI last year, use of GPT-4 to diagnose complex clinical cases or scenarios. And here is the distribution of our colleagues from medicine in blue. This is a clear Gaussian distribution, whereby you see on the left physicians that would need a repeat course, and on the right, some fantastic physicians that really made the diagnosis with ease. Now, if you're in an exam for the board and you don't know what the hell to say, this is where you are when you guess. And this is what GPT-4 does. So it's really amazing precision in this very study that needs to be repeated, but it's very, very impressive indeed. We did at the King's our own study with AI to improve the detection of undiagnosed heart failure with preserved ejection fraction. And so we took with large language models all reports of patients in our centers that had an echo and a measurement of a brain natriuretic peptide. And then we looked whether it would fulfill the ESC criteria for HFpEF as published by Chepe and Piske in the European Heart Journal. And then we looked at how many of our consultants really made this diagnosis well enough, and it was less than 10%. And so the survival diagnosis also showed that this was important if you made the diagnosis or not. So in the future, we will have an electronic health record, be it EPIC or any other, where in such a case, your co-pilot comes up and says, "Dear colleague, this is your co-pilot. Did you consider HFpEF? The criteria would be met. We would suggest a sodium glucose transport 2 inhibitor." And you say, "Damned, I missed it. But thanks to my co-pilot, I'm a good physician." And there's more than that. So patients usually wait quite a bit in the waiting room for their physicians. Of course, there are fantastic exceptions as those listening to this webinar, but many are not as good and the patients don't know what to do. And therefore, it is timely to have an avatar that talks to you, Amy, the Articulate Medical Intelligence Explorer, a large language model developed by Google based on an AI system optimized for diagnostic dialogue. So the avatar takes the history and it asks the patients, "How are you today? Any chest pain or shortness of breath?" And he said, "Yeah, when I walk up the stairs," and so on. And so when the patient enters surgery, you already have a probability of diagnosis based on history. And the question is the avatar better than the GP, let's say? So that's what they did. They randomized this to general practitioners, an AI ML algorithm based on clinical scenarios that were presented by an actor to make it standardized. And here are the results. You can see that the primary care physicians, PCP or Amy, in red and blue respectively. And you can see that Amy, in the red lines, was really better in both cohorts than the practicing physicians. But there's more than diagnostics, there's also prediction, and particularly in prevention, but also for interventions. We're very eager to learn what the outcome of a patient is. And this is machine learning for the diagnosis of myocardial infarction using cardiac troponin concentrations, plural, over time, plus some clinical data. And they were actually very, very good in diagnosing with this code ACS score in the external cohort as well as in the development cohort to diagnose acute myocardial infarction. And you can see that the C-index here is 0.953. It's almost perfect. The precision was very good to some degree, but at the higher levels of the score, a bit less than perfect. But still, it's quite impressive. But it wasn't just the diagnosis, it was also the prediction that was impressive, and I will come back to this. So when we want to predict rather than just diagnose, we want to use machine learning on multimodal data to enhance risk prediction and phenotyping. So how can we do this? Well, we need everything we have at hand: the genomics, metabolomics, proteomics, the CT echo and MRI of the patient, arrhythmias and ECG, valvular heart disease derived from the echo. So we need omics, imaging, and the ECG. We put everything in this basket called black box, where an algorithm will come up with clustering of all the data and provide deep phenotyping of the patients. And of course, with this, you can actually predict better and maybe also provide personalized interventions. And in this very code that I just showed you, they were not only able to diagnose myocardial infarction, but in those that survived, they also looked at outcome, and they used terciles of their score for cardiac deaths and cardiac all-cause mortality with quite a nice separation. We also have looked at this in the UK. The MyNab biobank that contains about 1 million patients with acute myocardial infarction. We took 400,000 with non-STEMI, looking at the gray score, and tested it in males and females respectively. And we found that in females on the left panel, it was much less precise than in males. And with machine learning, we were able to optimize it so that eventually this GRACE 3 score that's now available on the net is very precise, both in males and females alike. And we have a paper now submitted with 600,000 patients with non-STEMI for 10 countries to validate it with even better precision than what we found here. And in this very study, we were also able to extend the external validation for the GRACE 3 score for non-STEMI to model it in 10 countries and to actually determine whether the phenotype of the patient favors invasive management, as shown here, or not. And so this obviously depends on the risk, and we will look at this in more detail now in the real-world cohorts to see whether the senior RITA trial was rightly negative or was just neutral because of the selection of lower-risk patients, as we suspect. Because here, we even predicted in this huge cohort whether there was a low-benefit group where it was unlikely, based on a trial that we were used to learn the algorithm, to have a delayed or invasive treatment. But in the high benefit group, the early treatment was actually associated with less events than in those that were delayed invasive treatment. Now, this is a virtual trial, and I come back to this, but it may be the basis for a future trial that looks really specifically at phenotypes that are likely to benefit. And of course, we can also do this in prevention. And I know our chairperson is very interested in that. And this is an algorithm to identify suspected monogenetic FH for genomic testing. And you can see they took a huge cohort of over 100,000 subjects, a whole sequence from the UK Biobank participants. And then they came up with FH patients. And they fed the algorithm with all this data available in this cohort. And they came up with a reasonable prediction of patients that deserve genetic testing. It's not perfect yet, but it's a first attempt to get closer to this information for the clinician that has not rapid access for genomic testing. Here is another study published in the Genome Precision Medicine trial journal 3 years ago, familial hypercholesterolemia identification by machine learning using lipid profile data, just the lipids, triglycerides and all the rest we measure, as well as clinical diagnostic criteria. And you can see that the LDL, the machine learning algorithm compared to the LDL cutoff was significantly better in the initial medium prevalence cohort. In the low prevalence cohort, it wasn't. So that shows that the initial prevalence is very important for an algorithm to be useful. And this is another one. Then, of course, the question is, can we have an algorithm that suggests change in treatment to really adhere to the guidelines and to reach target levels recommended? This is machine learning applied to cholesterol-lowering pharmacotherapy, proof of concept, relatively small group for machine learning, particularly in secondary prevention. Nevertheless, it was interesting that therapeutic recommendations delivered by the neural network were increase statin dose, continue current therapy, refer to a specialist, add ezetimibe, add bempedoic acid, add PCSK9 inhibitor. So this is where the field is moving to have these assisted recommendations to reach guideline recommendations. So we can really refine risk assessment when we integrate everything we have at hand, from genomes, metabolomes, down to imaging, and then, of course, hopefully will reduce the risk by algorithms that help us to reach the right decision based on these data sets. And of course, we would like to have a digital twin that really mimics the patient that we have at hand, and we can actually then currently try to use any data sets we have, but in the future, we might even have variables, environmental information about pollution, about noise, about light, and so on, to really get a deep phenotyping of the patient. And then, of course, you could basically take this 67-year-old woman with heart failure with preserved ejection fraction. She's got a problem. And then, of course, the algorithm already recommends to the patient based on to the physician based on the information what is the most likely and most efficient measure in this very patient. So, but with the ESC, we're very keen to focus on quality criteria for artificial intelligence-based prediction models. So it needs a clear intended use, non-STEMIs, FH, you name it, not everything. And then rigorous validation in another country, ideally, multiple countries with 100,000 patients, maybe even more than 100,000. Openness for the data and software you have used, and of course in reproducing the algorithm as time goes on. And then you end up with an artificial intelligence co-pilot. That's what we learn from airline industry, that makes us faster, more precise, and safer. There has been also other attempts to make AI really future safe, and this is what the International Consensus Guidelines for Trustworthy and Deployable Artificial Intelligence in Healthcare proposed. It's the future test. It has to be fair, universal, involving different ethnicities, different sex, different countries, teachable, you have to know what the hell they're doing, usable, easy access, and then, of course, explainable also and robust. So that's the current thinking. The last question I would like to address is what is left for us. So, as you know, in history, the 19th century, when Industrial Revolution developed, physical force became less and less important to be successful in life. And today, even weak people on a wheelchair can be extremely successful. So you don't need force, you need intellectual capacity. But the question is it still as important to have intellectual work and capacity in the years to come? Clearly, memory is much less important than in the old days when the big professor with the white hair remembers everything. And the question is, how does this affect sonographers, imagers? I would argue that in imaging, most of it will be performed by an algorithm. In any manual field like electrophysiology or intervention, we will use AI clearly to help us, to make us faster, but the manual skills are not really taken over by robots yet. And the question is, what is the GP doing? So for the time being, it is not too distant future. AI will not replace clinicians who use AI. However, AI will replace clinicians who do not use AI. Now, what about the general practitioner? Obviously, empathy is important, time for the patient, building trust, being literate for AI, ML as a physician, later also for a patient. So to use critically AI and ML, and manual skills are still important, but AI and ML is learning as we speak. The question is, empathy? Really? And here I go to neurophysiology. Giacomo Rizzolatti is my hero at the University of Parma. He discovered the mirror neurons and their clinical relevance, and he showed, based on primates, that when we see somebody else, that he eats a banana or experiences pain, it lights up in our brain at the very same area. And this is what he called the mirror neurons, which are the basis of empathy as well. It is very useful if you are playing poker, but it's also very useful when you want to save somebody that's suffering and other aspects of it as well. And so they looked at how good is actually AI in this. And you would say, we're much better at that. Sorry, it goes back. Comparing physician and AI has been tested for chatbot responses to patient questions posted on a public social media forum. They asked questions about their disease, and then they were asked to qualify, to rate the quality of the answers of the avatar and also the empathy of the physician and the chatbot. And as you can see easily here, the chatbot was better in terms of ratings for quality of the answers as well as empathy. Obviously, the physicians didn't take the time to really be empathic enough or actually answer repeatedly on the questions of the patients. So we have to be careful here. And if possibly AI allows us to have more time for patients to really be good physicians with quality responses and high empathy. So what about science? These are my last few slides. Artificial intelligence will also provide us with the opportunity to do in silico clinical trials. And here you see you can do digital twins from patients in trials, and then you generate the neural network based on that. And with biosimulations, you can actually imitate what does it mean to have a myocardial infarction. How is the phenotype? How would this? What data do we need to predict this? And then, of course, you can have look at the disease incidence rates in a particular control cohort and in an interventional cohort, and then you can sequentially predict events. And of course, evaluating this, eventually you can look at survival rates on the very right and in the control and the intervention arm. And of course, you can test whether you're right or not. And this has been done, for instance, by my colleague, Dr. Durisso from the Hôpital Civil de Lyon. And you can see on the top, based on the data that he had at hand, on patients with a particular advanced lymphoma, that was then tested with a new antibody that you see on the lower panel on the right, and published in the New England Journal of Medicine. He predicted this result that you see on the top, and this was later published in the New England Journal of Medicine. So this allows us to predict with some certainty whether in fact a certain intervention is worthwhile to be tested in a large trial where we use physicians, we use patients, and a lot of resources for that. So with this, I would like to end by saying AI can combine clinical findings, biomarkers, imaging. It can also use portable information and genetics, of course. And then you can end up with a digital twin that's highly precisely reflecting the phenotype of a patient that will help us then for a personalized medicine that was a dream for decades, but now becomes reality. Because with this, we will be faster, more consistent, more integrative, and more precise. And with this, I thank you for your attention.
Thank you so much. That was wonderful. I mean, the capacity of integrating all the different concepts in AI that they're very advanced was amazing. So for everyone, put your questions in the Q&A and we'll go through them. I will start with one myself, if you don't mind. I really, we have an issue with the advancement of technology in clinical trials and the advancement of medicines, clinical trials, like you mentioned, in order to reach new medications to get approval, takes many years, takes millions of dollars, takes many patients. And you mentioned that with AI, we could decide in which ones we invest more time. Do you think we'll reach a point where we can use these algorithms to predict and get approval for medications based on that, or we will still need to conduct the clinical trials that we do now?
Well, obviously, in the first place, we need more in silico predictions, basically, to really make sure that this is a methodology that is consistently predicting events reasonably well. And I would think, initially it will help us to reach the right decisions, because we have, of course, seen a lot of neutral trials lately, because it gets more and more difficult to actually show an incremental benefit on top of what we already have. And so I think initially it will be a little helper for industry, for trialists, to reach the right decisions and to be more successful, and also use resources more focused on likely projects. And this is also an ethical issue for patients, to have patients randomized to trials that eventually are neutral is not very satisfying for both sides. And so I think that's, in my mind, the next step. Maybe in the future we go virtual completely. I don't know, but this will take quite some time. But I think it will help us. There's also now a lot of studies that looked at the structure of molecules, and they can predict on what structure will bind, for instance, to the LDL receptor. You can have small molecules that bind to the binding site of the LDL receptor, so that PCSK9, so the PCSK9 can no longer bind to the LDL receptor. And these can even be orally drugs. There is one now developed, and this can be predicted now with modeling of the three-dimensional structure of molecules. There's another paper where they actually looked at proteins from extinct animals that they were tested as to anti-proliferative properties and so on, with a reasonable prediction. So I think in basic and clinical science, this will help us to reach a decision quicker and more precisely. It will not replace our brain at this point in time, not in my lifetime at least. And what happens in 20 years, we will see.
Thank you very much. Very exciting times, and the productivity and the advancement in medicine could be exponential if this is the case.
Yes, and of course the profile of the cardiologist will change, you know. In the old days, when I was a fellow, it was very important to hear everything. And now it is much less so, because we have an echo that is much more precise. The ECG will be the same. People will no longer be masters at reading ECGs because it comes out of the machine. So we have to figure out what are now the really important talents, features, and skills cardiologists of the future should have.
Thank you very much. We have a question from Rob Oswell, our Director of Prevention. He says, thank you for the wonderful talk. I read that in China, they started a pilot virtual program called Agent Hospital. That is an AI-powered hospital with many AI physicians and nurses. If you looked into your AI crystal ball, what day-to-day changes could you see for human cardiologists 5 years from now? You basically address a little bit of this, but what are some more of your thoughts on the topic?
Well, I think because of the speed of this technology, when I run a clinic at the NHS, you know, I get a lot of patients. I have 15 minutes per patient, which is ridiculous, but that's what it is. So then in the future, I will have a patient coming in, and on my health record, it will pop up. Based on history, we suspect this patient has angina pectoris, or has heart failure, or has arrhythmias. And then you will also get an ECG analysis right away. And I saw that in the Mayo Clinic where I lectured lately. They already have this. You click on the ECG, it tells you how old is the patient, is it a male or female, and does he have normal ejection fraction, did he have AFib in the past, or does he have amyloid heart disease? And so you're already at a different stage. In seconds, you have a profile of this patient that allows you to be much more effective. And maybe you have then the time to spend a couple minutes with him to talk, because eventually also patients appreciate a physician with empathy. And you could see that from this trial, we have to be, if we're too busy, we're not very empathic, and we're not very nice in our answers so the patient understands. And so I think this will be very good. And then when we reach decisions, I think we will have also a co-pilot that already tells you. I think, based on what data we have currently, I would consider a sodium glucose transport inhibitor, as I showed. But the physician will be responsible legally. We have to make sure that this is our responsibility, as it is when we look at an echo ourselves.
Amazing, yeah, very good. And I love the concept of empathy. And when patients come to see us, they don't come only for a diagnosis and treatment. They also want to be heard. They want to see the doctor or someone with a nice suit like you have, or to feel cared for. I think that I love that concept, that we'll have more time for that. I have another question maybe about bias. And we know that these algorithms could be prone to bias, and there have been some examples based on the populations they are developed. How do we ensure to overcome these biases, in particular with minorities in trials?
Yeah, there is actually a paper in Nature or Nature Medicine where they showed that the algorithms can be racists. And so I think in cardiology, we have to make sure, as in trials, but also for registries where we develop algorithms, that they are really tested in multi-cultural, multi-ethnic populations. And that's in the UK, that's just particularly good, because if you take the tube in London, you can see that, there are people from every location around the world. And this is very useful to validate it. While in Sweden, this is less the case than in Switzerland. And so that's why we try to involve lots of different countries, and some are more useful. I mean, the US is also excellent for that very purpose. If you have unlike the early trials that were mainly white males, that you have females of a significant, ideally 45%. I mean, an infarction is always a bit more males, but that you have also people from Southeast Asia that we have a lot in London that have much more diabetes, much more comorbidities, more LP little a, and they have, of course, a different phenotype that the algorithm has to take care of. So I think it's very, very important. Also, we had a paper in Nature Cardiology, reviews in cardiology with Faiz Sanad on this very problem also in trials, you know, that trials are also considering different ethnic, cultural, sexual subgroups to make sure that it's more representative of the real world population.
Thank you so much. We learn a lot. I know I learn a lot, and we push us to be up to date with all this information that is coming our way. So I really appreciate, you know, your time and the experience that you gave us with this lecture.
My pleasure. Thank you very much for having me.
Thank you so much. Have a good weekend.
Thank you. Likewise. Bye.
Bye-bye.